So the second autoimmune keratitis is the peripheral ulcerative keratitis. Peripheral ulcerative keratitis is also like the moral ulcer. It is a painful, progressive and chronic peripheral corneal ulcer. Okay, it is a peripheral corneal ulcer, but it is due to non-autoimmune condition. As in the case of moral ulcer, we do not know the exact autoimmune condition, that why the immune complexes are depositing in this limbal vasculature and causing the vasculitis. But in the peripheral ulcerative keratitis, we know the exact autoimmune condition will be present. Okay. So etiologies. So there are multiple autoimmune conditions which can cause the peripheral ulcerative keratitis. The most common is rheumatoid arthritis, okay, followed by systemic lupus erythematosus, ulcerative colitis, Crohn's disease, hepatitis C virus and HIV virus. So these are the common autoimmune conditions which can cause peripheral ulcerative keratitis. The pathogenesis is same as in moral ulcer. What will happen? So there will be keratitis, okay. There will be vasculitis. This is the limbus, okay. This is the limbus. Whenever these autoimmune conditions are present, for example, if there is the rheumatoid arthritis, the immune complexes will deposit in the limbal vasculature, okay, in the circumcorneal region, at the limbus vasculature. These immune complexes will deposit and it will cause the limbal vasculitis, which will in turn cause the ischemia of the limbus and the necrosis, okay, the ischemic necrosis. So it will cause the ischemic necrosis of the limbus, okay. So this is the pathogenesis, as same like in the moral ulcer. Now, how the patient will present to us? As I am telling you again and again that there will be pain, photophobia, blood vision, lacrimation, redness, foreign body sensation and discharge. But the specific features for the peripheral ulcerative keratitis is the pain will be severe, and there is a hallmark of peripheral ulcerative keratitis, which is the crescent shape peripheral ulcer, okay. This peripheral ulcer, it will be in the form of a crescent shape, okay. Crescent shape ulcer will be present. With the severe pain, there will be a crescent shape ulcer, and this ulcer is spreading more circumferentially, okay, like in the periphery. It can spread centrally, but more it following the periphery, okay. So it is spreading peripherally and is a crescent shape ulcer. And remember, as we know, this is due to the non-autoimmune condition. So there can be the limbitis, okay. There may be the presence of scleritis and episcleritis, okay. Or other autoimmune visible clinical features may be present, okay. So the pain, crescent shape ulcer, limbitis, scleritis, episcleritis and other autoimmune visible clinical features may be present. So this is about the clinical features. Now the treatment. As the case is severe and can be a site-threatening condition, okay, so we will also initiate aggressive treatment. So we will start from the cyclosporin, okay. We will start from the immunosuppressant cyclosporin. We can also give steroids, and as the case is destructive, so anticollagenase can be given. Growth factors can be given, anticollagenase to inhibit this destruction and growth factors to promote healing, okay. So growth factors can be given. And systemic therapy. Remember if the patient present to us with the visible clinical features of systemic autoimmune conditions, so we will start. The treatment of choice is the intravenous steroids will be given, okay. So this is the initial treatment of choice if the patient present with the visible clinical features of an autoimmune condition. So we will give intravenous systemic steroids, okay. Alternative drugs to the systemic steroids we can give, for example, methotrexate and azathioprine. These immunosuppressant are good alternate for the systemic steroids. Methotrexate and azathioprine. Okay, these can be given. As like in topical therapy, the cyclosporine steroids, anticollagenase, growth factors. So the steroids, anticollagenase, these can also be given systemically. Okay, and for the secondary bacterial infection, we can give topical as well as systemic antibiotics to control the secondary bacterial infections. So these are the treatment options for peripheral ulcerative keratitis. Now the last one of the autoimmune keratitis, it is the interstitial keratitis. Interstitial keratitis, it is the inflammation of corneal stroma without the primary involvement of epithelium or endothelium. Okay, so first of all, there will be edema. Okay, this is the corneal layers. So there will be edema in the stroma, edema and inflammation. Initially, this edema and inflammation is not involving the corneal epithelium or endothelium. Okay, so this is called interstitial keratitis. Etiology, as it is also an autoimmune condition, so there are multiple autoimmune conditions. For example, the congenital syphilis is the most common cause for interstitial keratitis. So congenital syphilis, TB can also induce this condition, herpes viruses and leprosy. So syphilis, TB, leprosy and herpes viruses can induce interstitial keratitis. Pathogenesis. How is the stromal edema occurring? There can be two cases. The direct deposition of, when these infections are occurring, so there can be the direct deposition of the antigens. Antigens can be directly deposited in the stroma, okay, which will induce an autoimmune condition, okay, which will induce an inflammation, okay. There can be another condition which is called cross reactivation. So when these conditions are present, the body can mistakenly, the body immune system will be activated against these antigens, but the immune system can also mistakenly attack its own tissues, for example the corneal stroma, and it will cause the edema. So the direct deposition or cross reactivation can occur in interstitial keratitis. Okay, so this is the pathogenesis of interstitial keratitis. The clinical features are as common: pain, photophobia, blurred vision, lacrimation, redness, foreign body sensation and discharge. And there will be the edema, okay, if this is the cornea. So we will have the edema mainly in the center of cornea, okay. So at the center of cornea, this is the edema will be present at the center of cornea, and it will basically block the visual axis, will be mainly blocked by this central corneal edema. And there are a specific type of vasculature are present on this edema, which are called goosed vessels. Okay, so there will be these symptoms. We will have central corneal edema, and we will have goosed vessels on the surface of this edematous cornea. Okay, goosed vessels. So how can we treat the condition? The treatment options depends on the underlying condition. If there is syphilis, then we will get antibiotics such as penicillin. If this is due to the herpes virus, we will give antivirals. So treating the underlying condition will also treat interstitial keratitis. So the treatment option is these are simple, okay. So this was about the non-infective keratitis. We previously discussed the allergic keratitis, and now these were some of the autoimmune keratitis with their clinical features, pathogenesis, diagnosis and treatment. I also have prepared notes. I will get the link in the description. You can go through the notes and can learn more. Thanks for watching the video.